So I am delighted to welcome you to the May 2021 Lewy Bodies Support Group meeting. My name is Dr Rimona Weil, and I'm a consultant neurologist specialising in Lewy body dementia. We're thrilled that you're able to join us today over the internet, and we hope that you find this meeting interesting and helpful. We also hope that we'll be able to meet in person so we can actually see all of you again as soon as possible. Today, we're focusing the meeting on visual hallucinations, which can often be an issue in Lewy body dementia. So our plan is that I'm going to open the meeting with a short talk on visual hallucinations, how they happen, and the current treatments that we have for visual hallucinations. After that, we're joined by Professor Suzanne Reeves, who will talk about a new clinical trial that is opening at UCLH and also around the country to treat visual hallucinations. And then after that, we're going to hear an interview between John, who's a carer for his wife, Jenny, who has Lewy body dementia, with Claire Waddington, one of our rare dementia support team. And then we'll finish with a Q&A session with all of our speakers. And what we're asking is that you can submit questions at any time, but can you do that through the Q&A? And then we'll be able to see the questions, and then we've got plenty of time to answer those questions with our panel. And actually on that panel, we'll also be joined by Trish O'Hara, who's one of our rare dementia support advisors. So I'm just going to check if there's any. Oh, and we already have some questions in the mailbox, which is wonderful. So I'm thrilled that people are already interested in asking questions. So what I'm going to do is share my slides and get started with an opening about visual hallucinations. So hallucinations happen in Parkinson's and in Lewy body dementia. So I want to think about how they happen and some of the mechanisms behind them and how we can treat them. And actually, this the image that I've put on the front here is an image taken from a very beautiful but very sort of in-depth article that was recently published in the New York Times about a man and whose wife had Lewy body dementia, and her description of her hallucinations. And she described seeing a marching band going past her window. So this is a sort of a graphic of her experience. So the outline of what I'm going to talk about is to talk about what hallucinations are like in Parkinson's and in Lewy body dementia, a little bit about mechanisms and what we understand about how they happen, what we currently have in terms of treatments, and then I'm going to briefly mention some ways that if you're interested that you can get involved in research into hallucinations. So why do they matter? Well, they matter because they're actually very common. They can affect up to 75% of people with Lewy body dementia. In many cases, they're not bothersome at all, but in a small proportion, they can be distressing. And when they are distressing, they can be quite challenging to treat. And the reason they can be so challenging is that the very medications that we use to treat the movement symptoms, the Parkinsonism associated with Lewy body dementia, those treatments can actually worsen hallucinations. And some of the treatments that we use to treat hallucinations can worsen some of the movement symptoms. So we can sometimes be caught between sort of a rock and a hard place in terms of treatment. So what are Parkinson's and Lewy body dementia hallucinations like? Well, they're nearly always visual. And we don't know why that's the case, but they seem to nearly always be visual. They often involve people and animals, and they can be quite vivid and colourful. They often occur at a particular time of day and at a particular place. So people might say that they see them in the evening in a bedroom, for example. They tend to be quite transient, and they can sometimes come through the sides of the vision, and neurologists will call those passage hallucinations because they're in the sort of passage described originally by a French neurologist. Sometimes people can describe a sense of a presence, that they walk into a room and they just feel that there might be a person in the room, and when they look around, they don't see anybody. And over time, they can become more distressing. I'm just going to share with you this portrait because I think it's very evocative of visual hallucinations. And it was painted by Charles Doyle, who was the father of Arthur Conan Doyle, who wrote, of course, all the books about all the Sherlock Holmes books. Now, Charles Doyle was not diagnosed with Lewy body dementia, and that was because it wasn't even known about in the late 1800s. But he ended his life in an asylum and was said to be an alcoholic. But this was a self-portrait that he painted, and it's so evocative of some of the things that some people have described to us as clinicians caring for people who have hallucinations. So you might see that there's these creatures in the dark corners of the room. There's a dog sort of underneath his feet, and there's even a sort of an apparition coming into the sides of the vision, as we talked about with the passage hallucinations. And even the light is sort of like dim light, which is often where people experience hallucinations. So how do hallucinations happen? Well, even though they're very well described and they're very, very common, we don't know exactly why they happen. But we think that there may be a number of causes, and it could even be that it's a combination of those causes that they come about. And I'm going to go through each of these 3 causes in detail. So one of these is that it might be a change in the vision and in visual processing. It could also be to do with changes in brain wiring and networks, and also changes in the neurotransmitters of the brain. So thinking about vision and how vision changes in Parkinson's and in Lewy body dementia. So the changes can be quite subtle. Often they're not always noticed by people who have Lewy body dementia, and they can affect both the retina, so which is the layer at the back of the eye, but also the visual processing parts of the brain. So of course, when information from the outside world comes through our eyes, it goes into the brain and is then processed. And it's that whole processing infrastructure that can be affected in Lewy body dementia. Now, we can pick up some of these visual changes with sensitive tests. And some of you might have taken part in some of the tests that we've been doing in Parkinson's disease using these cats and dogs tests. And sometimes patients also describe more subtle symptoms as well, such as double vision or difficulty reading and focusing on words on a page, but it can be quite subtle. The important thing to say is that not everybody who has visual changes in either Parkinson's or Lewy body dementia gets hallucinations, but we do often see these 2 things together. So moving on to changes in the brain wiring, and I've put a picture up here of Angelika Zarkali, who's actually going to be chairing our Q&A session later. She's a researcher and a training neurologist in our group, and she's been doing a lot of the work looking at changes in brain wiring. So I mentioned that visual information is handled by our brain, and it's actually handled by a lot of the handling is at the back of the brain, which is the visual processing part of the brain. But further processing takes place by some of the front part of the brain. So the information is passed from the back to the front whenever we process visual information. And one of the things that Angelika has found is that those connections between the back and the front of the brain are damaged in people who have Parkinson's and people who have Lewy body dementia, especially in people who have hallucinations. And in the picture I'm showing you here, you can see in red, and the lighter the red, the brighter the color, the more changes there are in the wiring in people who have hallucinations. Angelika also looked at the networks, so not just the connections, but also the whole networks of how those are connected in people who have hallucinations. And she found that there are specific brain networks that seem to be affected in people who have hallucinations. And this network is particularly important in switching the brain between different states of alertness, if you like. So it seems to be that a particular network is affected, and also that the wiring is affected in people who have hallucinations. So now moving on to neurotransmitters. So neurotransmitters are the chemical messengers that we have in all of our brains. And there are several of them, but there are 3 particular neurotransmitters that we think are important in hallucinations. And some of them will be quite familiar to you. So one of these is dopamine. And dopamine, of course, is the neurotransmitter that is depleted in Parkinson's disease, and we replace using a medication called Sinemet. And we also use that medication in Lewy body dementia. So Sinemet replaces some of the dopamine, but if you have too much dopamine on board, it can change the threshold of how alert we are to things in our surroundings. And that could be part of the mechanism for how dopamine might be involved in hallucinations. And some of you might have experienced that maybe you or your loved one was started on dopamine, or the dose was increased, and that changed the hallucinations. So it can either trigger them or just make them a little bit more likely. And that's part of the challenges that I mentioned, that when we use dopamine, it can worsen hallucinations, which can make treatment tricky. Another important neurotransmitter is acetylcholine. So that's a neurotransmitter that we have in the brain that is important in thinking and memory, and also especially in visual processing. And it's one of the it's actually the focus of a tablet called rivastigmine and also donepezil that might be familiar to some people. Sorry. Whoops. problem with screen sharing that sometimes extra things pop up. So acetylcholine. So it's this. So this is a component in a medication that's frequently used in Lewy body dementia. And what we think is that by allowing more acetylcholine to be around, that boosts the thinking and memory, and that also should sharpen some of the visual processing and make hallucinations less likely. A third neurotransmitter that we think is likely to be important is called serotonin, and that's involved in sensory processing and also in behavior. And in a minute, when I talk a bit about some of the treatments, you'll see that that is quite relevant in a medication called pimavanserin. And also that's one of the neurotransmitters that's particularly involved in the clinical trial Top Hat that Professor Reeves is going to speak about in a few minutes. So currently, if a person comes to my clinic and they mention that they've got hallucinations and that they're bothersome, the current approach is a stepwise. So I'll look for any, maybe if they've just worsened recently, I might look to see if there's any infection on board that might be worsening hallucinations. I'll think about optimizing their sensory function. So are there maybe cataracts that we could think about treating, or maybe change the prescription so that improve the glasses so that visual processing is improved. I might talk about making sure there's enough lighting at home so in the evenings, so that as it gets dark in the evenings, we can turn up the lights so that hallucinations are less likely to happen. We'll also look at any medications that might be worsening confusion. So the sorts of things that might be doing that could be some painkillers, but also any medications that affect the neurotransmitters that I've just talked about. So particular medications are a group called anticholinergics that can also worsen confusion. And then I mentioned that some of the Parkinson's medications can worsen hallucinations. So we might think about lowering some of the Parkinson's meds, and that will be done by the Parkinson's team or by myself if you're seen in my clinic. There's always we have to weigh up the balance and risks of changing any medications. And I tend to do things quite slowly so that we can monitor the effects of making any change. So I mentioned acetylcholine, and the group of medications that can treat those are cholinesterase inhibitors. And what that means is that they stop the breakdown of acetylcholine. And the two tablets that we use for that are rivastigmine and donepezil, which can be taken, well, rivastigmine can be taken as a tablet or a patch, and donepezil as a tablet. I find that they can be helpful in around a third of people. And the main side effects are that they can cause some gastrointestinal problems, so sometimes diarrhea or even some nausea or vomiting. They can slow down the heart rate, so we always check the pulse, and sometimes we need to do an ECG before starting. And occasionally, there can be heart changes that mean that we prefer not to use cholinesterase inhibitors, and we use other groups of medications. Occasionally, if hallucinations are very distressing, then we might need to think about using antipsychotic medications. And there are different options, but the particular two that we would think about are quetiapine and clozapine. We need to use it very carefully because sometimes they can worsen the Parkinson's symptoms. So quetiapine would be a general first line, and clozapine can be very effective, but is a medication that can affect the blood cells, so it needs to be used in very specialist centres. So because we're so limited in our treatments, we're very keen to explore other options. And a new treatment has just been licensed in America called pimavanserin, and that acts at serotonin receptors. So that was the third neurotransmitter that I mentioned. And what was found in clinical trials using pimavanserin is that it improved hallucinations after 6 weeks. Now it's licensed in America. It's not yet licensed in the UK. It's very expensive, and it may come. But what I would say is, don't worry, because actually one of the neurotransmitter that pimavanserin works against is actually the same neurotransmitter that is being looked at in the clinical trial that Professor Reeves is going to tell us about. So we have got other options, even though we don't have access to pimavanserin at the moment. So just briefly, I just wanted to mention the research that we're doing. So this is some work that Angelika Zarkali, our clinical fellow, is carrying out to try to understand even more details about the circuitry that's going on in hallucinations. I've mentioned that she's shown changes in the brain wiring and also in the networks. And what we want to understand is even more details about the brain wiring, and that we plan to do that using a very strong MRI scan. Usually now, if you have an MRI scan, you'll have a scan at 3 Tesla. That's the strength of the magnet. But we now can use an MRI scan that scans at 7 Tesla. So it's a stronger magnet. It doesn't feel very different being inside that magnet, but it does mean that we have to be extra careful about any metal implants. But the benefit of using that extra scan is that we can look at the layers of the brain, and that gives us a lot of detail about the precise layering of the brain, and also the connections between the layers that we can't currently get using the standard 3 Tesla MRI scan. So if you're interested and you think you'd like to take part in this extra study, then you can email me or get in touch with Alicia or through people through Rare Dementia Support. I hope they don't mind me mentioning that. But certainly you can email me and I'll put you in touch with Angelika if you'd like to take part in that. So to summarize, visual hallucinations are common in Parkinson's and in Lewy body dementia, and we're starting to understand some of the causes of how they happen. Treatment is challenging, but we have got new treatments that are emerging, and we're especially excited about this new trial for ondansetron, which Professor Reeves is going to speak about in a minute. And we've got this new MRI study to try to understand some of the mechanisms behind them. And I'm delighted to introduce Suzanne. So Professor Suzanne Reeves is a professor of old age psychiatry and psychopharmacology at UCL. She's also academic mental health lead and an honorary consultant in care home liaison at the Camden and Islington NHS Foundation Trust. Her main clinical and research interests are to improve and optimize the treatment of delusions and hallucinations in older people, and her primary focus is in the Parkinson's disease spectrum and also in Alzheimer's disease. She is the chief investigator of the Parkinson's UK funded trial of ondansetron as a Parkinson's treatment, or Top Hat, and she's going to tell us all about that. So thank you so much for joining us, Suzanne.
Thank you, Rimona, and it's good to meet you all virtually. Last time I came to the meeting, I met people in person, and hopefully next time we will all be together again physically. But so I'm going to tell you a little bit more about Top Hat, and just want to make sure that everyone can see my screen. Okay, so thank you for the introduction, Rimona. So yeah, so I'm leading a trial of ondansetron as a Parkinson's hallucinations treatment, which is where we got the acronym Top Hat. And it's a multi-center trial. We have started recruitment and we've recruited 5 people so far, which we're so pleased about considering all of the restrictions around the pandemic. So what I'm going to cover is, I just want to tell you briefly why we chose ondansetron, what are the aims of the study, and what's it like to take part. So what might you expect if any of you are interested in taking part? Okay, so ondansetron is a medication that was introduced in the late 1980s, to treat nausea and vomiting. And I worked in cancer medicine in the mid-90s and used it, but only in people who had very severe nausea and vomiting because it was very expensive. And but what happened in the early 90s was there were 2 small studies that were carried out in people with Parkinson's who had very severe hallucinations, to the point where they needed to be hospitalized to have treatment. And they responded really well to somewhere between 12 to 24 milligrams each day of ondansetron. And what these studies found over a period of 6 weeks was that there was a reduction in the hallucinations. In fact, in a small study in 16 people, 14 people had complete resolution of their symptoms, 1 had partial resolution, and only 1 didn't have an improvement. And some people were having fixed false beliefs as well, 9 of the 16, and 8 of 9 had a reduction in those symptoms. Now, there were some side effects, but they were mild. There was a mild increase in constipation and headache, but no one stopped taking treatment. And there were papers at the time saying, could this be a new treatment for hallucinosis in Parkinson's? The problem was Glaxo owned the rights to how they wanted to use the drug, and they didn't go down that route. So it was only in 2006 that Glaxo gave up the rights to ondansetron, which meant that it became no longer so expensive. And there have been several trials since then in people with schizophrenia, and ondansetron helps when you give it in addition to their usual medication. And really, in 2017 and 18, when I was trying to find treatments that might be suitable for use, for which we had enough safety data in people, treatments that might be safer in the treatment of hallucinations and delusions, ondansetron really ticked all the boxes because the animal studies suggested it would treat hallucinations, and we had some indication in people with Parkinson's it might help. And we have lots of safety data from its use as a treatment for nausea and vomiting. So the main thing that we want to know is, will ondansetron be better than placebo? So that's a tablet that looks the same as the tablet looks identical but doesn't contain the drug. So when we carry out trials, we always have a comparison with a dummy drug, so that we know that any effects we see over and above those of the dummy drug are what are the real treatment effects. So we're looking at visual hallucinations. We want to see if ondansetron will also reduce delusions if they're there. And really important, we want to know whether this drug will be safe and well tolerated, specifically in people with Parkinson's. We want to know if ondansetron will improve quality of life. And we want to understand, we want to make sure it'll be cost effective for use in the NHS, because drugs like pimavanserin, for instance, are going to be very expensive because they're still owned by the drug company. So expense is really important, as you know, in the NHS. So they're the real questions we want to answer. So at the moment, Parkinson's UK are funding us to recruit 216 people with Parkinson's over 2 years. And we've identified 25 UK centres across England, Scotland and Wales, and we're hoping to move into Northern Ireland very soon. We're also in discussions with Parkinson's UK about widening the inclusion criteria to people with Lewy body dementia, because they are equally affected, perhaps even more affected by the hallucinations, and they happen earlier. So we're hoping to introduce that in the next few months. In order to take part, the person must be experiencing visual hallucinations, so seeing objects or people at least once a week, and they must be finding them troublesome. So really, the person who would be seeking treatment for them. The person may or may not have a diagnosis of dementia, we're being inclusive, and if the person themselves can't weigh up in the balance all of the information and make an informed decision, then it can be that a family member can help them make that decision and they can still take part. The only people who can't take part really are those who are treated with apomorphine, because the two drugs can't be used together, or they drop the blood pressure, and also anyone that has liver failure. But otherwise, most people will be able to take part if they meet those criteria. And we've already said it's funded by Parkinson's UK. So this time last year, we entered, well, we were in the middle of lockdown, and myself and the trial manager were trying to adapt Top Hat to reduce face-to-face contact and minimize any exposure to coronavirus. And we're keeping those adaptations because we don't know what's going to happen really over the next 2 years. And we want it to be as safe as possible for people to take part. So what will happen first of all is the person who is interested will receive information in the post or by email. They then have a telephone call to talk about the study in more detail. And they'd be asked to sign a consent form and give consent over the phone. Then there'd be a series of questions to make sure that there wasn't anything that might rule them out from taking part. And only if we really felt that that person would be able to take part would we invite them for a face-to-face visit. So this is just to show you the main scale that we're using to rate the symptoms. We're using a scale that the clinician would ask the person about different types of hallucinations. And we know that the main one would be visual. And they'll also, if you look at the bottom, item 7 is a global rating. So that's where the clinician finds out about the impact of those symptoms on the person's life. And so what we're needing is for people to score 3 on item 1, so visual hallucinations at least weekly, and at least 3 on item 7, so that they're troublesome at least. So when people come to clinic, in fact, some centres around the UK are doing visits, and some centres are doing clinics, and it varies centre by centre. But for people who seem eligible, they'll be seen by a clinician who will take a blood test to check liver function, check movement, but without making physical contact, just by asking people to show their movements. And we've got a very handy app. So it's a little device that you can see people can hold in their hand, and we're able to carry out an ECG, so get a heart tracing, without making physical contact and without any leads. So again, we're reducing any physical contact in the context of the pandemic. But it also means the clinician could go to the person's home and give the person the little app, they put their fingers on it, put it on their knee, and the ECG reading comes on the clinician's smartphone. No information's there on the phone apart from the tracing. It's then sent to myself, and myself and a cardiologist check to see if it's okay. So that's one of the things that one of the changes we made because of COVID. What happens then is a computer will randomly say who gets drug and who gets placebo, and neither the clinicians or the person themselves or anyone will know which the person's receiving. Anyone who has symptoms that aren't being treated sufficiently during the trial can have what we call rescue medication with a drug that's currently used. But otherwise, people will stay on drug or placebo, and we won't know right until the end of the study. The other change we've made because of COVID is that once a computer's made the decision, the manufacturers will arrange for a courier to send the drug directly to the person's home. Again, we were avoiding all that contact by going to pharmacy, having the drug dispensed, and being in contact with several people. And what will happen then is the team will call the person who's received the drug, and we'll run through exactly what they have to do and tell them how many tablets to take for the next 2 weeks. So just before I go on to how we monitor the medication and safety, I want to say just a tiny bit more about ondansetron. So ondansetron blocks a particular type of serotonin receptor, a different receptor than pimavanserin. And it's a receptor that is involved, that's highly involved in regulating the way chemicals are released or stopping their release in the brain. And what we know is from animal experiments, when ondansetron is given, it increases acetylcholine. So one of the chemicals that Rimona mentioned is really important in vision. And it reduces excessive dopamine release, which can make hallucinations worse. So that's what was found in animal experiments. And we believe that ondansetron will improve the precision of visual information processing. Now, those same receptors that are so crucial for what we think are ondansetron's actions in the brain, they're also present in the gastrointestinal system. And what ondansetron can do is slow down the kind of motility of the gastric system. And that's the reason why it can make constipation a little worse or precipitate it. So one of the main aims of the study is that we want to minimize any constipation from happening. And if it does happen, we want to make sure we reduce the dose. So we're trying to do as much as we can to reduce the possibility of what is the most common side effect. So I've said that, we know one size doesn't fit all, and it may be that people aged 85 might need a smaller dose than someone aged 65. A lot of the work I've done has been around determining what's the best dose for the person of the right age and the right gender and the right body weight. So every 2 weeks, there'll be a dose increase to the end of to the end of 6 weeks. And there'll be safety monitoring calls at the end of week 2 and the end of week 4, with very clear guidance about whether or not the dose would stay the same, whether it would reduce, or whether it would increase. And we built this in as a means of really minimizing side effects. So by the end of week 6, each person will be on their tolerated dose, and the maximum will be 3 tablets, but people could be on anywhere between 1 to 3 tablets. The other change we've made because of COVID is that there was originally a face-to-face visit, quite a long visit at week 6 and week 12. What we've now done is that where possible, people will have a video consultation or a telephone consultation if they can't access video. And they'll be asked about their symptoms, side effects, and run through the rating scales, quality of life and other things over the phone. They'll then come into clinic to have the ECG again, to make sure that ondansetron hasn't made any changes to the heart rhythm, and a blood test to check the concentration of the drug in the bloodstream. At week 12, there'll be a very similar assessment, but no ECG this time. And at the end of week 12, the person will stop taking the study drug, and a clinician will take away any unused tablets and take it to a pharmacy, or send it to me, and I'll take it to a local pharmacy here in London. Between weeks 18 and 24, there's more follow-up just to see how the person is and see if there's any re-emergence of symptoms, if the symptoms had resolved. It may be that alternative treatments might need to be offered. So all in all, someone will be in the trial for 24 weeks, 12 weeks on treatment and 12 weeks off. And at the end of the study, we'll know much more about whether ondansetron can treat hallucinations, whether it's safe, and also just about the feasibility of some of the changes we've made, like the ECG app and the video calls, to see whether people like them and think they're of good quality. So we have, as I said, we have sites all across the UK. We're still a little bit light in the Midlands, but we're working on that. And anyone who wants to find out more can email myself. We have a Top Hat email address. And Parkinson's Take Part Hub also have information on the trial. It says a 65 pence anti-sickness pill could treat hallucinations. And there's also an information sheet that tells you in more detail about the study on the Take Part Hub. So that's another way of seeing in detail the sites and getting more information. Okay, so well, thank you for listening. I'm going to be around for the Q&A. So hold those questions in your mind and or send them in. And yeah, more than happy to tell you much more about the trial if you're interested.
Thank you so much, Suzanne. You've made that really clear and extremely helpful to hear in detail about who can take part and what it will be like as well. We've had some questions already coming in, so I think it would be great. Always good to it's wonderful to hear from everybody. And I hope that you're enjoying a slightly new format. We're doing this over Zoom, which we're hoping will be slightly more interactive. So thank you for telling us all about Top Hat and the trial. What we're going to move to now is an interview between Claire Waddington, who's one of our rare dementia support advisors, and John, who is a husband and carer for his wife, Jenny. So she was diagnosed with Lewy body dementia 3 years ago, and he's supported by his family. And they have pre-recorded a video together where Claire has been asking him about his experiences of caring for his wife, Jenny, including some of the things that we've touched on this morning, including some hallucinations. So thank you both in advance for this, and I'm going to hand over to Alicia, who will get this going. Thank you.
So good morning, everyone. It's really lovely to be here today with John, who supports his wife, Jenny, who has a diagnosis of Lewy body dementia. So thank you so much for being here with me today, John. If we could start by you telling us a little bit about your wife's hallucinations and the coping strategies that you both use to manage with these hallucinations.
Right, well, the hallucinations have really not started straight away when Lewy body dementia was diagnosed about 3 years ago. The first clue I got that she had something going wrong was we were standing washing up and she referred to me in the third person. So then I became the classic Lewy body symptoms, which was the imposter. So, and I quite often go into imposter mode. Quite often I'm John, the husband mode. But yeah, it depends, and it's really caused by if you have a slight little disagreement. If you have a slight disagreement, then Jenny's brain switches over, sort of switches me over to imposter mode. The hallucinations didn't really start early on. They've been more prevalent recently, in the last 12 months, I would say. And she would see, she really sees a hallucination and interprets an inanimate object as a real thing, a living thing. We do discuss them. She knows they don't talk or they don't eat, and she can't communicate with them, but still to her, they're real people. And the classic one was when I put the chairs out on the deck for the summer, the garden furniture. They have little curved white legs on the chairs and a round table. And Jenny immediately converts these chairs into ladies sat around the table. And this is quite classic. And I have put them away for the winter because it got really quite hard work. But I'm going to have to get them out in the summer. And I have tried covering them up. But if one of the legs sticks out under the canopy, then that becomes a person hiding under the canopy. And it's so difficult. And even plants and trees can become people. It's quite amazing how the brain can do it. As far as coping with the hallucinations, it's incredibly difficult because whatever logical thing you say to the person with the dementia, they will challenge it and they won't understand it. There is no logical way you can explain it to them. I've tried all sorts of absolute unquestionable logic, and still Jenny won't accept it. And this is a classic symptom, called the Capgras symptom of the Lewy body dementia. You can be as logical as you can, but they won't take it on. So this can be incredibly frustrating. So coping with it is, I think you just have to cope with it, but you can't manage it very well.
Absolutely. Thank you for describing a bit about the hallucinations, and you've touched on Capgras there as well. So would you mind telling us a little bit more about the delusions that Jenny experiences as well? Because I know they're having quite a big impact on her and on you as well.
Well, when you say delusions, do you mean hallucinations? Because most of what Jenny experiences are hallucinations. That's something which she sees, which nobody without the dementia would see. So I don't know how would you describe a delusion as opposed to a hallucination?
Absolutely. So a hallucination is perceiving something that isn't there, hearing voices when people aren't there, whereas a delusion is a belief that isn't true. So that is like along the lines of Jenny believing that her house is not her home, or maybe that you are an imposter, that you're not the real John.
Right. Okay. Yeah. The delusions which you're describing are have been fairly common, not as much as the hallucinations, but she will, and she was from the early stages thinking that the house she was living in was not the house which was hers, even though she recognized all the furniture and all the doors and things like that in there. And she, the one we're in at the moment, she will quite often not believe it's her house and keep asking for me to take her home, which is a bit distressing. And in fact, recently she thought that her home was across the road, so a neighbour of ours, and she has been known, until I've taken sort of action to stop her doing it, to go out of the front door in the evening, if I perhaps dropped off to sleep, and knock on the door of the neighbour and say, "Can I come into my house?" Which he's a very understanding neighbour, fortunately, so we have that sorted, and you know, we have a good relationship. But she finds this a lot, and sometimes she wakes up in the morning and thinks she's on a boat.
So, John, you mentioned about Jenny sometimes thinking that you're an imposter or maybe not the real John. And I wondered if you could tell us a bit about the strategies that you use when she is believing that you are an imposter.
Well, I used to have a strategy of going out of the house when I became the imposter. Usually I found it was the trigger would be a slight disagreement, very minor disagreement, but this was like operated a switch in her brain, and I would go out of the house, take the mobile phone, phone her up and say, "I'm just out so in the park or whatever, I'll be back in a minute." And I come back and knock on the door, and she'd say, "Oh, hello, where have you been?" and greet me with open arms. And that worked quite well, but now it's a bit difficult. Certainly in the winter, it's quite difficult to do things like that, and you just have to just bite your tongue, bite your lip, and go out of the room and wait for the imposter stamp to be taken away from you and come back. But you find that going out of the room is a decent strategy, rather than sit there and just grunt, even if you're watching the television. So that's the beauty of a recording machine on the television. So that is the sort of the main way of coping with it. But you do find the imposter stamp sort of waxes and wanes, and you can't predict it, except, as I say, with these slight disagreements, because we've never had arguments, big arguments at all, and we've been married for 54 years now, so it's a long time. You get to know someone quite well. But it is a very sad, horrible disease to put up with for both of us, really. Jenny doesn't really know what's going on, I don't think, but I do, and I see it. It's quite depressing.
Thank you for talking through the impact that it has on both of you, John. And just as a final question, is there anything else that you feel is important for other carers of someone with Lewy body dementia to know, just from your experience?
I do find one of the main benefits, because we've moved up to Northampton now to be near our daughter since Jenny was diagnosed, and my daughter is a great help to me, and my son now has moved up close by, so I've got the family up with me, and I do find that is a great support for the carers, because the carer needs to be looked after as well, because they carry quite a heavy burden on their shoulders, and I'm sure you realise that, you know. The people who've got the dementia a lot of them don't really know what's going on at all, but the carers are fully aware of everything, and you worry about it was I think as a actual, the patient doesn't really worry too much about it, because yeah, I don't sleep that well because I worry about Jenny, but Jenny sleeps really well because she doesn't really worry about it. It's a bit sad, really, but that's the way it is. And yeah, and the only other thing is that it would be so helpful to have a, as you called it previously, a buddy, or several buddies I could ring up and talk to and discuss ways we manage our the people we're caring for. That would be great.
Thank you so much, John. I completely agree about being connected with other carers who are also going through this experience. And also, I think it's really important that you've highlighted how important it is to validate the person with Lewy bodies in terms of their experiences with delusions and hallucinations as well. Is such an important thing to do. So thank you so much for being here today and for talking us through your experience. We hugely appreciate you opening up about this.
Okay, you're very welcome. Lovely to talk to you as well.
Thank you so much. Thank you, Claire, for the interview. And John, thank you very much for sharing your experiences. I think you touched on some really important points there. You've mentioned delusions, and a lot of the experiences that you shared, I can already see from the chat that have really resonated with people today. And some of the whole point of this support group is actually being able to share some of these experiences. So thank you so much for that interview, because it really, I think it's so helpful to hear what you've experienced and for other people to hear what you've gone through, and also to any sort of things that you've found that have been helpful. And another thing that you mentioned is the real importance for thinking about not just the person who has dementia, but their partner and their carer. And I think that's particularly important in Lewy body dementia, because there can be so many aspects that are sort of physical and sort of physically caring for somebody, but also sort of the sort of mental strain that can be involved. So that's one of the reasons why we've set up this group, and one of the reasons that we think it's so important to make sure that the carer is supported, so that you can get some extra support through rare dementia support, and also through schemes like the buddying scheme. So thank you. What we'd like to do now is move on to the question and answer part of the meeting. Hopefully when we're in person, this would be the point when we would break off and have a coffee, which would be so nice when we could do that in person. So you'll have to have your coffee at home. But I'm going to welcome back everybody who's spoken today onto the panel. So we'll have, so Professor Suzanne Reeves will be able to answer questions specifically about Top Hat, but she has a wealth of experience in as a psychiatrist in all things to do with Lewy body dementia. So it would be fantastic to hear from her. And as I said, you actually spoke at one of our first in-person meetings. I think it must be 2 years ago already. Yeah. We have John is well, Trish has appeared. So Trish O'Hara is one of our rare dementia support advisors, and she's particularly experienced. She's got loads of experience, but particularly experienced in rights and entitlements. And I think somebody's already posted a question about questions about the sort of logistics and thinking about changes in home arrangements. So Trish, it's wonderful to have you with us. And Dr Angelika Zarkali is going to be chairing our Q&A session, and I've mentioned some of the research that she's doing. So, and actually if there's any questions specific about that, Angelika can answer those. She's, as well as being a researcher, she's also a neurologist in training. And John, hopefully if you're able to turn your camera on and your microphone, that would be wonderful. We'd love to welcome you back onto the panel. So I think we have a few questions. Yes. So
thank you, Rimona. We have quite a lot of questions actually from the Q&A session, and as well people have been emailing and then chatting. So it will be an interesting discussion, I think. So first, should we start with some of the questions from the Q&A? So we have a question from Kate. It has been a difficult journey getting a diagnosis Lewy body dementia, and the house is not suitable for husband's long-term needs, but she's concerned about the impact of moving, as this will be a completely different area, and is asking for some guidance and direction in terms of what to consider and further information. So I thought maybe Rimona, you might want to kind of give your input, and then maybe Trish might have some ideas as well.
I'll give only very brief input because I think Trish is going to be extremely knowledgeable about this. But one thing you touched on there was that there's a journey to get to a diagnosis of Lewy body dementia. And we hear this again and again. And that's one of the reasons that this support group is about Lewy body dementia being a rare dementia, because even though it's not rare, it has its own issues and can be quite a journey to get to. And part of the reason it can be difficult to make that diagnosis is that often in the early stages, things can be quite subtle and people can present to different specialists. So, and also things can progress. So it's not always clear at the beginning what the condition is. So I'm not surprised to hear that it's been a journey, but I hope that it's been helpful to at least know what's going on, and that getting some of the support from our dementia support could be helpful. I'm going to hand over to Trish. Before I do that, John, I think there might be just a little bit of interference. So I know I said put the microphone on, but do you mind just muting? Because I think there's a little bit of interference from your microphone, and I'm going to mute as well while Trish speaks.
Hello, it's Kate. Yes, I think probably this is the most stressful time for you because you feel like you need to move. If the home doesn't feel like it's going to work, your home doesn't feel appropriate, you might need to move. And we all know that moving is stressful, and it's going to be very stressful moving with someone who might have some issues with change. Without a doubt, it's going to be a difficult time, but nonetheless, it's a good plan. It's a good plan to move. I would suggest, in my experience, that you need to move as the carer. Put your carer needs very high here, and say that you need to move near people, perhaps to a place that's not isolated. So, you know, the temptation to move to the country as we age, I'm always fascinated by, because moving to the country might seem idyllic, but it's quite an isolating place. So maybe near a town or a village or a city, or in the heart of a city, if you can, so that you get good services, or services that can access you easily, including through the winter. Because again, rural areas, fantastic, beautiful, but quite difficult for carers to access in the heart of winter, particularly if it's snowy and you live at the top of a hill. Those sorts of things do matter in the end, really. We don't think about them when we're moving, but it's a good thing to do, is to plan and maybe consider, and again, the doctors here will have much better experience than me about this, but if somebody's living with Lewy body, there's a fair chance they might get some Parkinsonian sort of symptoms as they go along. So maybe thinking about living on one, perhaps a bungalow or one surface, so you can avoid stairs and avoid that risk potentially. Think about having an outdoor space if you can afford that, so that the person can get in and out and get lots of exercise in a way that doesn't affect you too much, so that they can get in and out of the house without you worrying that they're out on the road. Because again, people with visual differences might be higher risk on the road, so that you get some peace and they can go in and out and have some space, and you don't have to constantly be on the go. Making sure maybe that you're as near friends and family as you can be, if possible, and that you also perhaps do a bit of research on what sort of services are locally available. Perhaps have a look on the local authority website, have a look at their carers centre on the website, and have a look at the local authorities. The website will give you a feel about how involved in public services they are, really, and see if there's any day services and what the local care agencies might be like. Give them a ring, speak to them and say, we're thinking of moving to the area. Do you have availability for care? Which at the moment, Kate, you may not need, and it's possible you may never need it. But if in the future you do, it's good to have that plan in place. And each area is quite different. I'll stop now. I've probably spoken for too long, but it's a good plan, Kate.
Perfect, thank you. I hope that was Kate found that useful. So there's a lot of questions that people have emailed in, actually, that I think have quite the same theme. So I thought we might touch on them next. So it's about how to manage kind of hallucinations and delusions about the house or the partner. So there's a few different people describing and that their loved one doesn't recognize the house that they've lived in for over 40 years. They have some ideas about other people living in the house or are in danger of getting evicted. And it's very difficult for the carer to deal with those, as they sometimes feel that as there's a conspiracy going on and they're conspiring with them. So I think there's kind of 2 points to touch there that they're asking for. One, what is the kind of medical things that we could do to help with that, which I thought, Suzanne, you might like to comment on. And secondly, from John, whether there's any particular strategies. I think you touched on that already in your interview a little bit, but what strategies have you found useful kind of dealing with those sort of symptoms? So, Suzanne, would you like to maybe touch first?
Well, I wonder whether, it might be better doing it in
the other order
first, just because what we tend to do is, first of all, find out how the symptoms are affecting the relationship and when these symptoms are likely to happen, and think about what works with the person, who the family member. So it'd be really good to hear John's answer first, and then I'll follow up with what next. If that's okay.
Okay, can you hear me? Taking myself off mute now. Yeah, very interesting. It's interesting that everybody seems to have experienced pretty much the same things as I've experienced. I knew it was quite common, but not quite as common as that. I think that one of the most important things for the lady who said she's got to move is to move somewhere where you've got support. You know, I used to live in Bath, which, as you probably know, is a very pretty city. And I've moved up to Northampton, which is not quite so pretty, but it's got its benefits. But the most important benefit is to be near my daughter and now my son, so they can offer me a lot of support when I have problems, when my wife has difficult days, because you do get very difficult days, and they can pop around because my daughter's only 10 minutes away, and they can come over for the day, and I can go off and have a sort of few hours respite, which is very important as a carer. As far as managing it, really the only way you can manage these things which happen to your partner's brain or whoever is to step away, go out for 10 minutes and come back. Yeah, because there's no point there contesting what your partner is telling you. There's absolutely no point in contesting it. You get so frustrated. So this is what I do, and it's the only thing which seems to work, because at the moment, until we get some medication which can stop these hallucinations, which I'm very interested in, but I'm a bit disappointed it's only for Parkinson's, but I assume that's because Parkinson's Society are funding it, and they don't want to fund a Lewy body. Is there a Lewy body society which could fund another trial or a parallel trial? Anyway, that's my my feeling on it. Over to the next speaker.
Yeah, so thanks, John. So I suppose just to say, we are working on Parkinson's UK are actually willing to fund an additional 90 people with Lewy body dementia to take part, and we're just in the process of making sure that we get the study design right and the numbers right. But that is what we're planning, a big amendment that should go in the next couple of months. So I think watch the space, because we realise that we need to widen the inclusion.
Yes, because as you said, the Lewy body hallucinations are probably more severe than you get in the Parkinson's, and so they should have the same sort of opportunity as the people with Parkinson's. I know it's all to do with funding, but I'd like to sort of put my name down as a first, or my wife as a first participant.
Thank you, John. Oh. So So I suppose from my perspective, we see the belief that a carer or a loved one is an imposter can happen with any type of dementia, Alzheimer's dementia, Parkinson's disease dementia, but also Lewy body dementia. And I think it's one of the most difficult ones. I think the only more difficult one is the belief that the spouse is having an affair, because then even going out and going away from the person for a while, that just feeds into the suspicion. So I think what you're saying is exactly right. In that moment, it is reality, absolute reality for the person. And I suppose that one of the things that I try and do when I see people in clinic or from within care homes, I try and establish just how fixed that belief is. And if it fluctuates, then that's easier to manage, because, as you say, you step back, you give the person a bit of time, you come in, you reorientate them, and after some distraction, they may well not believe that anymore. And I think the other, if someone does have a more fixed belief, it can be so hurtful for their spouse or their family member that they might begin to react in a different way. And again, that can feed into that thing that this person isn't acting like their usual self. And some of it's about orientating, or just, first of all, reminding them who you are. I think particularly if it's if the feeling that someone's an imposter is about you being the wrong age, it's worth orientating around age. But also not getting defensive and actually saying, oh, it's me, I love you, and I think if those things don't work, then you're right. I think giving some space.
Step away. I found step away has worked quite well. And as far as being a different age, actually, my wife will quite often mistake me for my son, who's he's over 50 now, but he doesn't look anything like me. But mistake me and talk to me as if I'm her son, and she'll say, "Oh, you'll be going back home soon." Things like that. There's just flash in and out of your brain. It's a very complex machine sitting up there in your skull.
Yeah, and I suppose the other thing is that there are interventions that have been adapted that were originally developed for people with Alzheimer's dementia, and it's kind of what you call a manualized intervention. So there's a kind of checklist that a person from the clinic will work through with the family member and say, when did the things happen, what might help, and just think about strategies with the person, and that has been adapted for people with Lewy body dementia and Parkinson's, and that can be quite helpful, because I think, so particularly around hallucinations, about adjusting the lighting, working out the timing, and thinking about the types of delusions and when they might be more likely to be expressed.
Yes, I understand that, and it's quite often the sundown symptom, which is when the brain gets a bit tired and all these sort of funny, weird ideas come in to the patient. I just go to sleep, but Jenny has these things happen. And the strange thing we know is we moved to a house in a village, but it's got all those facilities, but close to my daughter, because we're out in the countryside. I didn't want to move into the town. And the house we moved to has all the doors are identical. They're all white panelled identical doors. You can probably see one behind me there. And that's a cupboard door. And all the rest of the doors in the house have been changed, and they all look the same. So this, to Jenny, causes huge confusion, because if they're closed, she doesn't know what's behind the door. Because we have a cloak rooms, even the wardrobe doors are like that. So this can cause confusion. So I've been advised to label them, but silly things like that, which the brain can't analyse. You see, there's a door. What's behind it? I don't know. Is it a utility? Is there a cloakroom? Whatever. So something which has happened to us, which may happen to other people. Perhaps we should paint them all different colours.
But I think one of the things that that I learned was just how difficult it can be sometimes for people, just going on the subject of doors, to the depth perception, actually working out that that is a doorway and this is where I need to open it. Do you know, and it's actually just, there can be quite a lot of confusion just getting out of a room sometimes, if that's the issue for the person. And you're right, it's about saying, making it really clear.
And an issue with keys and locks, and certainly remote controls. Well, we've abandoned remote controls or trying to operate them for televisions because, they are quite complicated. A bit like computers really now, remote controls, especially if you've got a video recorder. Anyway, this I can operate it, and I think one of the sort of real benefits is to have a decent recording machine or video recorder of some description, whether you get it on, get it from a utility or whatever, but record lots of programs which quite often you can't see, or the opportunity is not to see because you've got problems and your Jenny goes to bed early or whatever. But if you can record lots of programs in the can, then you can watch them in the afternoon, for example, when things are fairly peaceful. Well, that's quite a useful tip for people.
Thank you, John. So I suppose the other thing I would say is, if sometimes the beliefs that people have are more distressing than others, particularly if someone believes that there's an imposter who means them harm. And that's really the stage where people like myself, so psychiatrists, might be more likely to be involved, because and part of what we're doing is thinking how to minimize the distress and how to minimize the risk, because there might be a risk of hitting out if someone feels threatened. So I tend to see people who have more severe symptoms, because a lot of these symptoms are milder. So where I tend to come in is giving advice about the smallest dose of any medications that might be effective. I think the first step, as Rimona mentioned, would be to use the rivastigmine or donepezil, because it boosts acetylcholine, which can be helpful, definitely with hallucinations. But and I think, we tend to start with that because it's the safest of all the potential drugs we might use. The other thing that I would also explore is whether or not that person's feeling more threatened because their mood is low. And when someone's mood is low, they're more likely to perceive things as threatening and anxiety generating, and what might be, kind of, someone thinking that you're your son rather than you. But actually, if someone's depressed, it may feel something more fundamentally suspicious. And so treating depression is another thing that we would do, or anxiety around that. And we'd only use medication beyond rivastigmine if someone was so distressed that they were at risk to themselves or their loved one. But really what we're doing is thinking of as many strategies as we can to avoid medication.
Yeah, well, Jenny's on several. Jenny was on rivastigmine, which she's now on donepezil, and recently been prescribed sertraline, which is an antidepressant. But we're finding that the build-up of the drug has been quite traumatic. It's caused quite a lot of side effects. In fact, some occasions almost made her unconscious with the effect of it's just a drug. So I was advised to sort of give her the drug every other day, and we seem to have got over that hurdle. But talking to the GPs, it takes about 6 weeks for these drugs to be fully effective. And do you agree with that?
I think It varies, but it can take several weeks. The dose would very much depend on how old someone is.
She's low body weight as well, you see, so she's
right.
only over 7 stone. So I've been told that body weight is a factor, or someone mentioned it in the presentation. Because like alcohol, if you've got a low body weight, you can't absorb it so well.
So I suppose the main things would be to think about. It'd be worth checking her. It'd be worth making sure that her heart rhythm hasn't been affected, because if she's very sensitive to medication, then sertraline and other medications can affect the heart rhythm slightly, and all medications can cause changes in blood pressure as well. So I think
I do check her blood pressure. We have got a machine, but it seems to be quite high in the morning, but stabilizes after lunch. Whether that is, I think mine is a bit higher though. Sometimes in the morning, certainly it's high sometimes, times of extreme stress, but there you go, that's what happens. But we don't really know. I do sort of question sometimes the medication she's on, whether it's actually doing anything at all, because you wonder sometimes whether if you just withdraw the medication, what's going to happen. But that's probably a very dangerous thing to do.
Well, I think if a medication isn't suiting someone, if it's causing them side effects and there's no apparent improvement, then it's all about, I think everything that we do is really about a balance, the risks, the benefits, how it's affecting the motor and function, memory, well-being. And I think, some drugs don't suit some people, even though a different antidepressant might work better for her. And I think the main things to discuss, so if you think something isn't working or you think there are side effects, then it's worth withdrawing it, just tapering it down slowly.
Yeah, I do talk to the GP and the consultant on a regular basis, because I monitor her condition 24/7, as most of the carers do.
There's 2 people have asked about the doses of rivastigmine, and I just thought I'd mention that because I think if 2 people have asked, they must be very interested. Obviously, the dose needs to be discussed with your caring neurologist or psychiatrist. But rivastigmine, as I mentioned, comes as a tablet or as a patch. So the highest dose that you can take as a tablet is usually 6 milligrams twice a day or 12 milligrams. But the patch form goes up to 13.3. Which is sort of equivalent to the 12 milligrams. So that's the top dose if people are interested in that. Angelika, I think you had some more questions if you want
to. On the rivastigmine, Loretta is asking whether it can worsen Parkinsonism symptoms and whether it's worth adding rivastigmine if people are not troubled by hallucinations.
So an excellent question about, so whether if somebody doesn't have hallucinations, would you use rivastigmine to improve cognition? And actually, absolutely, because rivastigmine was designed, if anything, for cognition first, and then we've noticed it may help hallucinations. So yes, it is helpful for cognition, and we would recommend that. In some people, it can slightly worsen Parkinson's symptoms, but not necessarily. So it's definitely something to discuss with your treating neurologist or psychiatrist. But you don't just have to go on it if you have hallucinations.
Can I come in on the rivastigmine? Can I just make one comment on rivastigmine?
Yes.
Jenny was on, she couldn't take the pills because she has a phobia of swallowing a pill. So she went on to the patches, but we had to come off the patches because the patches caused so many sort of red sores all over the body because you have to put them on every day and you lose track of them, and they can be really quite aggressive. And we had to get cream to combat the sores when you took the patch off, because it leaves quite a bad patch on the skin. So that's just something to consider when you go on patches.
No, you're absolutely right. The patches is not always an easy solution, and we've got a few patients where it can cause rashes. But when it works, it's great. That can have its own problems.
Yep.
Any other questions?
Some more questions about medications. What prompted kind of the ondansetron to be trialed in people with Parkinson's hallucinations in the first place? What kind of was the first inspiration for it?
Well, in 1987, when it was being developed, so what happens is a drug is tested first in animals, and in animal models. So there are genetic mice with genetic problems that leave them quite deplete of acetylcholine and have visual problems. They responded very well to ondansetron because it increased acetylcholine and it increased their visuospatial function. So at the time, people were saying, oh, ondansetron might help visual memory and it might reduce hallucinations. And there was so many papers written in the early 90s about it. And it was in the early 1993 and 1995 that these very small studies were carried out. And I think the pharmaceutical industry is driven by many, it's not driven by the same, the motivations differ. And I think for them, Glaxo decided to go down the route of nausea and vomiting. And ondansetron is still the best drug to treat nausea and vomiting. But I think it was a missed opportunity. So, but those studies were really promising in animals. And can I just touch on the several other people asking about when will the trial be open to people with Lewy body dementia, and are they not recognised as the same condition? So they're not recognised as the same condition, they're recognised as a spectrum. And some of the discussions we've been having is just how similar the two groups are. And what we've decided is to actually look at the groups separately. So that's why it's taken us time to put together our proposal to Parkinson's UK. So what we aim to do is to have the main study for people with Parkinson's, that's 216 people, but we'll also recruit 90 people with Lewy body dementia. And that will be enough people to tell us, to give us enough sense of whether the drug will act similarly in people with Lewy body dementia, so that by the end of the trial, people with both conditions would be able to use it if it's effective. So that's really the aim. And I think it could take 2 to 3 months to do this, because we have to go through the medicine regulatory body first, get their approval, put in the amendment, and get the ethics approval, and then we'll be ready. But do watch this space, and anyone who's interested, do email me on Top Hat, and I can direct you to your closest site.
Perfect, thank you.
Yeah, great.
And we actually just mentioned that for the very kind of personal specific questions, the direct support team will be in touch, because we might not be kind of appropriate to answer it in the Q&A box. Just on the subject of Top Hats, kind of the people are really interesting, clearly. There's a question about how can you actually do the questionnaires and the subscale if people don't have insight and they don't understand that what they're seeing are hallucinations, and how do you deal with that difficulty?
Yeah, so when we kind of teach the clinicians about how to use that measure, we're very explicit about the fact that they can use any information available. So sometimes a person has really quite vivid, is able to give a really vivid description, but a person who lives with them, or if someone's in a care home, then care staff. And what we'll do is make sure that we record really carefully where that information came from, who was spoken to, so that we've got a good sense of how much that symptom's changing. So I think people often don't remember episodes or the change in that from one day to the next. And I think we do rely on family members.
Yeah, perfect. Thank you. We also have a question about how you deal with tactile hallucinations, so sensations of touch that are not there. So I was wondering whether, Rimona, you might want to comment on that.
Yeah, thank you. So it's a very interesting question from Terry. I hope it's okay that I mention that you mentioned that your husband has these hallucinations of, as if there's a weight pressing on him, and also some kind of that he's in different positions. And that's less common, but that's probably related to a similar process, that it's about misinterpreting information that's coming from outside. So I mean, I think there's no easy solution to any of these, but I think that's one of the things that's definitely come out today. But I think that what I would do is approach this as a hallucination. So I would use the treatments that we've talked about, so rivastigmine or donepezil first. I would approach that first, and then, I mean, the top hat as a trial is specifically for visual hallucinations, so you wouldn't be able to come into the trial for that. But the approach of using treatments that we use for visual hallucinations for these physical hallucinations, I think would also be appropriate, and also to recognise that that's probably what they are. So if they're transient, that they're likely to change over time. Suzanne, I don't know if you wanted to add anything to that.
Yeah, no, I agree completely, and I think the other thing I would say is that I'm currently in the process of applying to Parkinson's UK with psychologists from Lancaster University and UCL to look at a mindfulness-based intervention for people with any kind of hallucination, because mindfulness is about just a kind of, some of it is about thinking about, reflecting about your body, how it feels, reducing anxiety about any sensations or things you're hearing or seeing. And it can be helpful it's been helpful for young people with psychosis, and it's being suggested as a treatment for people with Parkinson's and Lewy body dementia. So I think actually thinking about the impact on the body and trying to come at it from the distress or the actual sensation, and see if you can encourage a bit of reflection and normalize it in a way. Think about things that might distract from that strange sensation that's happening. But I agree, it is a hallucination, and should respond to the medications that we use to treat other hallucinations.
Thank you, that was really useful. And now we have a few questions for Trish. So the first one is about arranging your own home care rather than going through social services. So not sure how to go about it and whether local councils may contribute to some of the cost.
Okay, that's a really important question. I mean, the thing about care is it can come in all shapes and sizes. You will, of course, potentially get support financially, but not everybody is going to get financial support. What we tend to think about is the cutoff is 23,250. If you've got that in savings, you're pretty much likely to be self-funding. That doesn't mean that you wouldn't want an assessment done by the local authority, because the local authority can point you in the direction of local care agencies. The person has said outside of care agencies or of local authority, which is fine. You can do it. You can go directly to agencies yourself by looking up your local agencies in a directory. Just put care agency into Google, into your local area. But the thing about going through the local authority is that they are what's called approved services. It doesn't mean that the local authority know the ins and outs of them and that they're perfect, but it does mean they've got on an approved provider list. So they might get audited a little bit more. They might have jumped through a bit more hoops just to be of a certain standard. If they're providing care, they're also monitored by the Care Quality Commission. But again, that's not very frequent. So sometimes having the added bonus of knowing that the local authority have inspected them at least once is a good thing. You also could potentially, you could be qualify for carers hours. Now, as a carer, that is unmeans tested. Your needs assessment for the person living with dementia, that is means tested. So it's your savings will affect whether you qualify for hours or for money. But your carers assessment is unmeans tested in some boroughs and counties, not everywhere, but in some boroughs and counties, they will offer 3, 6, 8, sometimes 12 or even more hours unmeans tested, so you don't pay for those. You will have to go through a financial assessment. My advice would be is that you always make sure that your assessment as a carer is separate to the person living with dementia. They might ask if you want to do a joint assessment. My advice is do separate ones so that your carer's needs and your well-being can be put forward too. Means that you might get some unmeans tested hours, which means that you can bring a carer in whilst you go out, and it might be called respite. You might think of that as respite, so you can get out for a walk or go out and do some chores or just get a break, and the person can stay with you, the person that you live with. might be your partner, and that gives you a break. That person is going to be difficult to introduce people, and everything John has said and everything Suzanne has said about anxiety-driven hallucinations and delusions, particularly around imposters. The thing about dementia that is important is we often know that people don't think their way through dementia, they feel their way through dementia. So if the feeling is anxiety, bringing in a stranger to the house is really difficult. So you can bring people in very carefully, and always, always, always talk in a way that everything is okay. Everything is okay. We're fine. All the bills are paid. This is a person who's coming to help me do the cleaning. They're helping me. They're helping me as the carer. I need some help and they're great. It's fine. Everything's fine. As the person with dementia might have some raised anxiety, the really important thing and the hardest thing, I know from experience, the hardest thing is that the carer's anxiety goes in the opposite direction with, it's great, everything's fine, this person's great, I'm so glad they're here, this is brilliant. And they can be introduced very carefully, and you can possibly get your own carers and bring them in for just a visit to start with, and then bring them in. I would always say that you start introducing care before you actually need it. I think that's the best way to do it, if you can afford to, or if you get some financial support from the local authority, which you may or may not qualify for. But just bringing someone in as a visitor, or someone who helps about or sits around a little bit, so that they become a little bit more familiar with the person with dementia, and that the person with dementia gets a bit familiar with them, hopefully. And then they can start being involved in some care support. As time goes on, you would increase their hours maybe, and you can bring in a team of carers. So you can go directly. There's lots of different ways of doing it, but don't dismiss the opportunity of an assessment with your local authority, because it can be very helpful.
Thank you, Trish. Do we have time for a very short relevant question, Rimona?
Yes, let's squeeze one in if that's all.
Perfect. It's just on a very similar note. I think there's a lot of anxiety on this about eligibility for continuous healthcare funding, and whether people with DLB are eligible, and how they might go about accessing that.
Do you want me to come in here, Angelika?
Yes, please.
Okay.
Yeah.
So CHC funding is the $1 million question. And of course, what we need to work out really and accept is that basically it's always been this way since 1948, that our healthcare is free at the point of delivery, NHS, but our social care has never been free at the point of delivery. It's always been means tested, and people have always contributed. So when a person living with dementia, when they become sicker, if they do, if some of their needs are clearly driven by health, and that the main driver is health, then it might be seen that this is, because it's a health-driven need, it might therefore start qualifying for what might be considered free at the point of delivery, continuing healthcare. But it is quite a high bar. And what my experience tells me is that most people who apply for it actually get refused first. There's like a first refusal, and then there's an appeal, and a lot of people win on appeal. It's a flog. You have to jump through a lot of hoops. It's hard work. It's not easy, but it's worth it, because it means that your whole care package would be delivered for free. In other words, by the NHS. It's usually easier if they're living in a nursing home, but it is possible, with some case law proving that people can qualify for CHC funding, continuing healthcare funding, in their own home, but it's harder to achieve, although people do achieve. And basically it's important to remember that you can as well ring us directly at the Rare Dementia Support Team, and if at the point that you're thinking you might make applications like this, you can ring us, and one of our advisors will talk with you one-to-one on the phone, give you some individual advice. And it's really important to try and remember that at those points you can make direct calls for one-to-one support. We don't fill out forms for you, but we can certainly talk to you about the sorts of needs that might drive towards continuing healthcare, often involving stuff most obviously health driven, such as incontinence, double incontinence, that sort of thing, when someone is unable to eat or swallow potentially, if that happens to them. And this doesn't happen to everyone with the dementias we're talking about, but if some of the needs are driven by health, and that may include some behavioural needs, but that's harder to prove. but some physical needs, mobility issues, unable to move about the house, we start to see health becoming the main driver and maybe getting funding from continuing healthcare. It's usually further down the line than we expect, though. Okay.
Thank you.
Just a couple of things before I wrap things up, and we have slightly overrun, but I hope that that's because of enthusiasm from everybody with questions. There was one question that I'm not going to go into a lot of detail, but somebody asked about that they had one appointment with a specialist and haven't had anything else, and what have they missed? So it's very hard to answer that because it's obviously totally individual. And what I'd say is that Lewy body dementia, as you probably can see from our discussion today, is complex and it's an evolving condition. So I think if you're worried about having missed anything, it is worth going back to the GP and just saying, and especially if there are any specific issues that are troublesome at the moment. Also, there's one thing on the chat I was just going to prod Professor Reeves, because I think there was a question from somebody about access to Top Hat from Esther. So I don't know if you were going to answer that, maybe directly on the Q&A.
Yes, I was, but it seemed
you got distracted
while everyone else was talking.
So I'm just going to let you answer that in the background. Yeah. So
we can also kind of send answers via email to the newsletter, as we did last time, because there are a few remaining questions. Yeah.
Absolutely. So any questions we haven't dealt with that are still outstanding, we'll answer as a follow-on through email. So I first want to thank everybody who's been part of today. I mean, I think it's been so wonderful to have the interactions that I think we've been able to have through this webinar. So first of all, thank you, John. Absolutely, thank you to you for the interview that you did, and also the conversation that you had with Suzanne has been so tremendously helpful. People have put in the chat how helpful they found it. It's absolutely resonated with people. So I think people have found that extremely helpful, that you've been open and shared your experience. And I think for me, that's the number one most helpful part of today, was you joining us and being part of it. So thank you so much, John. Thank you. Thank you to Trish for your very practical, helpful insights, and some things I'd never thought of before about when thinking about moving. Make sure you move. It's obvious when you say it, but make sure you move close to where you can get support. So very helpful. Now I know about you even more. I'm going to definitely be in contact. Thank you, Professor Reeves. Wonderful to have you now as a professor. Thanks for your information about Top Hat. There's clearly a lot of interest. And it's, as we've said, it's Parkinson's, but it's not just Parkinson's. So Parkinson's dementia definitely can already take part. And there's also a sort of grey area where it's like, is it Parkinson's dementia or is it DLB? Those patients can still take part. And then when it's clearly DLB, likely to be possible in the next few months, actually. So very, very positive. And there's sites all around the country. So just because you're not in London doesn't mean you can't take part at all. We're looking more widely. Thank you to Angelika for hosting the Q&A and answering questions in the background. And I think there was also a question about your research. Is it restricted to London? Not necessarily. So get in touch. And if you're eligible, we have got a small budget for travel. I want to thank all the people who've been helping in the background. So Alicia Willoughby, Nikki Zimmerman, Livy Wood and Millie. So much help with sort of the technical support behind all of this, and the background sort of setting this all up and getting things ready for today, and all the work that you do for rare dementia support. So I'm going to wrap things up. There's a video when we finish. There's a video from the National Brain Appeal who partially fund rare dementia support. So if you're able to stay on and watch the video, then that would be wonderful. And thank you to everybody who's joined. Your questions and your responses have totally made it a very interactive meeting, which has been sort of hopefully practical and also sort of educational for all of us, certainly including me. So thank you very much to everybody. And just to say, our next meeting, we're already planning the next meeting that we hope will be likely to be the end of November or possibly early December. We'll send out a date about that. We're still in the planning stages, so if you've got ideas or things that you'd like us to cover, then let us know. And at the moment, we don't know. Might be virtual, might be in person. So we'll watch this space to see where we are with that. So thank you again to everybody.
Yeah, thank you, Rimona.
Thank you, John.
Hello, my name is Eva Tate and I'm the Major Appeals Manager and Manager of the Rare Dementia Support Fund held by the charity the National Brain Appeal. The National Brain Appeal raises money as the dedicated charity for the National Hospital for Neurology and Neurosurgery and UCL Queen's Square Institute of Neurology. The National Brain Appeal raises funds for rare dementia, supports 2,000 members to help individuals living with rare and early onset forms of dementia, their families, friends, and healthcare professionals. And we also hold several other funds for FTD and dementia research. The funding helps not only the support group meetings in London, but also the regional support groups, admin and support staff, and all other associated expenses, including the new online support groups. When things return to normal, there are travel and accommodation bursaries available to help members attend the meetings. This year, we've raised our fundraising target to 300,000, and this will rise further to 350,000 by 2022 to develop and extend the service in the areas of education, support, and research, with the ultimate aim that everyone affected by a form of rare dementia will have access to specialist information and support, as well as contact with other people with a similar condition. We apply for grants from grant-making trusts, foundations, and livery companies, and have a wonderful group of supporters, some of whom are here today, who fundraise for us in an amazing variety of ways. We would love it if you would like to sign up to our RDS fundraising newsletter to hear more of these stories and receive news of how we can support this community. We have had people do head shaves for us. We have had a gentleman drive across the Mongolian steppe in a VW Polo, and we have lots of people who take part in runs and virtual runs as well. At the end of February, we held a gala dinner called Mission Possible, where we raised 110,000 for the expansion of rare dementia support. And we are delighted to announce that in line with this expansion, the charity is committed to raise up to 7 million to create the world's first centre of excellence for rare dementias. If anyone would like to discuss any fundraising ideas or the new capital appeal, please do feel free to email me or my colleague Alexis, our senior fundraising manager, who will speak about the innovative new ways you can be involved in fundraising for RDS, even during this challenging time. Thank you very much.
Hello, my name is Alexis Gebby and I'm the Senior Fundraising Officer at the National Brain Appeal. I just want to start off by saying a huge thank you to all of you who already fundraise for RDS. We really appreciate all of your incredible efforts, especially at this difficult time. My role at the National Brain Appeal is to look after all the amazing people taking on various fundraising activities for us. We have had people challenging themselves to run marathons, cycle long distances, climb mountains, and even take on skydives, all whilst raising money for RDS. We also have wonderful fundraisers out in the community who organise golf days, hold coffee mornings, host choir and carol concerts, and even shave their heads. These people ensure that more people like you can be supported through rare dementia support. If you're interested in becoming one of our fundraising heroes, then please do contact me. I am here to support you with your fundraising, and I'm more than happy to chat about any ideas that you may have. While at the moment it isn't possible to take part in a sporting challenge or hold a big fundraising gathering in your local community, we do have some fundraising ideas, such as taking on a solo virtual run or walk, hosting a quiz for your friends or family online, asking for birthday donations in lieu of going out, or even donating money that you may be saving by not travelling to work or buying your daily coffee. Do get in touch with me if you would like to get involved. In the meantime, take care and we hope to see you soon.